Well, it's a pleasure to be here. I'm David Erlinger from Lund University in Sweden, and I'm glad to present the INFINITY-SWEDEHEART RCT and the one-year clinical outcomes. I think Dean has summarized the mechanism very well, but we can repeat it a little bit. And the important parts are, when you put in this bioadapter, it behaves like the best-in-class drug-eluting stent that we have on the market. It's easy to deliver, you get excellent lumen and low residual drug diameter stenosis. But after 6 months, the links open up after the polymer has been absorbed. That allows for positive remodeling, which Dean has shown will increase the lumen or maintain the lumen compared to a rigid structure, a cage stent. It also gives dynamic support and restores the hemodynamic modulation, the pulsatility, compliance, adaptive coronary flow, vasodilatation to nitro, etc. So it restores physiology. So the INFINITY-SWEDEHEART is a register-based randomized clinical trial. What we mean by that in Sweden is that we use our excellent quality registers for PCI and myocardial infarctions, both as a basis, so we get the baseline characteristic from the register, and we do the randomization within the register, and the register actually tells you that this could be a patient for this trial. And then we use the registers to follow them, and we have decided to follow these patients at least 5 years, maybe longer. So we wanted to evaluate the potential superior clinical benefit after 6 months in reducing non-plateauing event rate in this population. So the primary endpoint was non-inferiority, and the powered secondary endpoint was TLF from 6 months to end of follow-up, and TVF from 6 months, and TLF in ACS for 6 months to end of follow-up. The thoughts about that is that the first 6 months, it behaves exactly like any other drug-eluting stents. So that first 6 months data will kind of pollute the end result. We wanted to have an all-comer population, so we allowed up to 85 years old patients. We allowed both CCS and ACS, and up to 3 lesions could be treated with the device. We had some exclusion criteria, but as few as possible. We excluded left main artery disease, bypass graft, instant restenosis, CTO, and osteal lesions. These are the 2,400 patients enrolled in 20 sites in Sweden. We had a CEC that was blinded, and we had study oversight with the EMC and core lab, etc. We randomized 1:1 to DynamX or to Onyx drug-eluting stents. And now we have followed up for 12 months and will present the results. So the demographics were rather typical for stent trials. What sticks out is that we had very many acute coronary syndromes, 77%. And for example, 23% STEMI, and which is rather unusual in early studies with drug-eluting stents. We had more than 40% B2C complex lesions. We had some bifurcation and calcified lesions, and we had a lesion length of about 24 millimeter. And pre-procedure, it was 87% stenosis, so this was really significant lesions that we treated. Post-procedure, there were excellent results with 1% diameter stenosis according to the operators. So this is the primary result. The primary non-inferiority endpoint was met with a p-value of less than 0.0001. DynamX had 2.35% events, and Onyx had 2.77. The numerical lower rates in the DynamX was mainly driven by target vessel MI and ischemia-driven TLR. There was very little instant restenosis in both groups. But now we come to the more interesting analysis, and that is the 6 to 12 month landmark analysis. And here we can see what actually happens when the bioadapter unlocks, uncages, and restores physiology. Suddenly we see that the events plateau for the TLF. You can see to the left here that there are only 2 events out of 1,200 patients in the DynamX group, while the Onyx continue to accrue events like in any other drug-eluting stent study we've seen in the last 20 years. P-value for superiority is 0.0079. Also TVF, which is a little bit more mixed group, probably events not related to the bioadapter, also in the same vessel. We also see a significant effect with superiority of p-value of 0.01. And we have the powered endpoint of ACS, which is a higher risk event. And we can see here, the first 6 months, there is no difference between the devices. That is according to the design of the bioadapter. But after 6 months, you can see that there is only 1 single event in the bioadapter group out of more than 900 patients, while the Onyx continue to accrue events as usual. We also looked at high-risk lesions. We looked at LAD lesions. You know that LAD has much more torsion and pulsatility and higher restenosis rates than other vessels in the coronaries. And here we can see a few events in the bioadapter group and significant superiority for the bioadapter compared to the Onyx. We also have small vessels, but also has a higher restenosis rate. And here we see actually not 1 single event in 250 bioadapters from 6 to 12 months, and superiority with a p-value of 0.03. Long lesions had similar results, not 1 single event in more than 700 patients for the bioadapter. If you look in a forest plot, you can see that there is no significant p-value for interaction, which means that all groups benefited similarly from the bioadapter. So in conclusion, the INFINITY-SWEDEHEART study is a large-scale, multi-center RCT that compared the bioadapter versus a drug-eluting stent in a representative, clinically complex ischemic patient population. Low and non-inferior TLF rates at 12 months was fulfilled with a very low p-value. Significant reduction in TLF and TVF and flattening of event curves after 6 months in favor of the bioadapter in pre-specified landmark analysis that showed superiority. There was a substantial clinical benefit for the high-risk subgroups, including ACS, and consistent effect across pre-specified subgroup, such as LAD, small vessels, and long lesions. So the evidence from this large-scale INFINITY-SWEDEHEART RCT confirms the results from the bioadapter RCT trial and suggests that the bioadapter may represent the long-awaited solution to flatten the event curve following PCI, marking a significant advancement in coronary interventions. Thank you for your attention.